Gentlemen, hi guys. To anyone who is preparing for the RCGP simulated consultation assessment, just put together the feedback statements from the RCGP, results, and just to highlight a few things that I believe would be very important for anyone who is sitting this examination. So let's proceed. So I'll just talk about the areas I've highlighted with the arrows, the red arrows. So this topic says relevant psychological or social information insufficiently recognized or responded to. The examiners felt that you needed to explore the patient's social or psychological situation further to establish context. So in the exam, you'll find several scenarios or several cases where patients will come to you with several problems, and you need to establish relevant social or psychological situations, impacts, for you to really understand why this patient is worried and how this symptom or problem could be affecting them. For instance, an elderly patient who's having back pain or osteoarthritic pain, joint pain, do they live alone? How are they coping at home? How is their mobility at home? Have they got someone who supports them? What do they enjoy doing? How is this affecting them? So you need to elicit that. Someone with, maybe Dupuytren's contracture, for instance, what do they do? How is it affecting them? Carpal tunnel syndrome pain, how is it affecting them? What is this pain restricting or stopping them from doing? You need to elicit all of those kind of things. It says here, the next arrow we have highlighted, it says, be curious about your patients and their experiences. Establish the impact of an illness on their lives, which is exactly what we said. So establishing social impacts, and then of course social circumstances, living conditions, support at home, if they've got carers, if it's relevant to ask about that, you need to ask about that. And then the psychological impact as well, how it's affecting their mental health, is it stressing them out, those kind of things. You need to be exploring those. Let's move ahead. The next one says the management plan relating to prescribing of medication was inappropriate or not reflective of current practice. So these are generic feedback statements, so they're not personalized. You know what it means? What I mean is, so it's not like this is not a feedback based on my personal experience. It's a feedback for all candidates. Okay, so every candidate that did the exam will see exactly the same feedback statement. So this is why I'm sharing it with you, because if you're still going to write this exam, then you need to know what the examiners are looking for. So here it says, let me start from here. You may not have developed a plan at all where a prescription was needed. You may have prescribed or failed to stop an inappropriate medication or issued an incorrect dose. So what happens here is that maybe a colleague of yours prescribed the wrong medication for a patient, and maybe the patient didn't take it, but the patient read about it and then decided that they don't think this medication is right for them, and they've come to complain or clarify and possibly complain to you, and you've received their complaint and you've handled the issue, but you haven't clearly stated that they shouldn't use that medication because it could be harmful or inappropriate. So you need to clearly state that, this was a wrong prescription. I want you to either discard this or give it to the local pharmacist who knows exactly what to do with that medication, but don't take that medication. You need to clearly state that. You may have prescribed when no prescription was needed. So this exam is such that if you do something, especially your management, if you do something that you shouldn't do, that can cancel all the good things you said. So if you said 5 things in your management, if 4 of them are correct and 1 is incorrect, that 1 incorrect management plan can be enough for you to fail your management. Okay, it can just cancel all the good things you've done. So very careful. Don't prescribe if you shouldn't prescribe. Don't refer if you shouldn't refer. And refer when you should refer. Because not prescribing when you should prescribe will make you fail management. And prescribing when you shouldn't prescribe could also make you fail your management. This may also refer to the suggestion of over-the-counter or non-prescription medications. It says here, for instance, for example, perhaps tamsulosin rather than finasteride should be first line for LUTs or BPH, for instance. And if you want to start patient on finasteride when they've not, having issues, try tamsulosin, then that's a prescribing, fault. Let's proceed. I have highlighted this one. Let's start from here. You may have suggested inappropriate or unjustifiable investigations. Exactly what I said previously in the slide. So if you recommend maybe an X-ray, chest X-ray, when you shouldn't really be getting a chest X-ray, so saying things like, just to be sure there's nothing else going on, be very careful with that. So do you really think a chest X-ray should be requested here? Or are you just trying to be 100% safe when there's really no indication for you to be panicky and getting that investigation? You know what I mean? Or you may have arranged investigations where none were needed. In this case, patient with simple back pain, uncomplicated back pain, no red flags, and you want to get an MRI scan of their back or even an X-ray of their back, no history of trauma, no red flags. And why do you want to get an X-ray? Why do you want to get an MRI scan? You can manage conservatively, at least on safety nets, and probably arrange a follow-up if needed. Let's go down to the next highlighted points there. You may feel that it will be better to be on the safe side by ordering a battery of tests, and whilst understandable, these may make you appear indiscriminate. So you can see that you may just want to be on the safe side. You want to play it safe, you want to keep it safe. And you just say, let's just get a chest X-ray, let's just get an X-ray of your knee because I suspect this could be osteoarthritis. Could you manage, if you have a high index of suspicion of osteoarthritis, no trauma, no warmth, no redness, no severe swelling, the patient is systemically well, you're not thinking of septic arthritis or gouty arthritis, or inflammatory arthritis. Why do you want to get an inflammation and imaging of that knee? I know in clinical practice, we commonly do is we get X-ray of the knee to confirm, the presence of osteophytes and all those osteoarthritic changes in the joints. But you need to double check with NICE guideline. Can you refer these patients for physiotherapy, prescribe painkillers without getting an X-ray of their joints? Very likely, yes. So very careful. Don't just do things to be on the safe side. That can make you fail. I mean it. Because when I looked at my management, a lot of cases I thought I would do very well in management. And I had some of them I had failed in management section. And when I had to review the cases with some of my colleagues who are preparing for the exam, they made suggestions of, maybe you shouldn't have actually offered to refer this patient. And I reflect on it, I was like, yes, maybe you shouldn't have referred these patients. Yeah. So the next one, they say plan is a tutorial where you share and action your supervisor's results, list, and vice versa. It's something you can do if you're still preparing for the exam. You can consider reviewing that with supervisor. Let's proceed. This one says the management plan relating to prevention, health promotion, or rehabilitation was inadequate or inappropriate. So in exam, you could get one or more than one cases that have to do with health promotion, preventative medicine, or health promotion or rehabilitation. If you get a patient with COPD, for instance, worsening COPD, you need to be thinking of pulmonary rehabilitation. It's written here. So the next point, for example, patient with COPD could benefit from pulmonary rehabilitation, smoking cessation, flu vaccination. So if you think of flu vaccination, pneumococcal vaccination, have you had a pneumococcal vaccination, which is a one-off vaccination, the annual flu vaccine? Do they smoke? If yes, we consider smoking cessation. Another thing you need to be thinking about asthma, COPD is occupational impacts. Are they working in a place where they could be having, allergies, pulmonary allergies that could be worsening their asthma or COPD? You need to be asking those kind of things. Did you focus mainly on which inhaler to provide? So inhaler technique and adjusting the inhalers is very important if needed. Or some of these non-medical things, could actually be very important as well. Here it says someone with, no, that's not it. So consider whether there are important areas of prevention, health promotion, or rehabilitation you might encourage. For example, do you know some simple exercises for mild knee pain? Do you understand how to support someone locally with smoking cessation, weight loss management, those kind of things, weight loss management. So there was a case I did very well in. I think I suspect it's because I was able to, bring in the aspect of weight loss management, which I felt were very important in that case. The next one says, so the person's agenda, the patient's agenda, health beliefs, and or preferences were insufficiently explored. And I've highlighted here with arrow. It's important to understand the context of the illness and attach importance to the subjective aspects of medicine. This means always seeing the patient as a unique person and being curious. Then valuing patient preferences and expectations. For example, a patient whose neighbor has lung cancer may have fears about their own cough. It's all about valuing the patient's opinion and not just being, the consultation should not be doctor-centered, it should be patient-centered. You need to do that. The whole consultation in your SCA and even in real life is all about making the patient well and valuing the patient's experiences, the health beliefs, what they think, the ideas, concerns, and expectations. And of course, they also consider the impacts of the situation in their life, psychological impacts, social impacts. You need to consider all of those. Let's move ahead. Data gathering was insufficient to enable safe assessment of the condition/situation. Ensure you consider the presence or absence of relevant red flags. So in this SCA, because they want to avoid you telling most of the patients, I would like to bring you in to examine you, just to have a clearer idea of what exactly is going on. They want to avoid you, nudging the patients, to come in for an examination. They want you to complete the management without having to do that. So they'll give you a lot of relevant information in your preparatory case. The information that you have before the patient appears on the screen. You have a lot of useful information there. However, you still need to elicit relevant presence or absence of, relevant red flag symptoms. For instance, a patient with back pain, even though your colleague may have ruled out, red flag symptoms, you still need to check that those red flag symptoms are still not present. You need to ask. Patient with cough, you need to rule out red flags for lung cancer, and things like that. Patient with hemorrhoids, you need to rule out, red flags for bowel cancer, the straining, and all those kind of questions, Let's move here. See, for example, if you decide a patient has mechanical back pain, have you excluded caudal equine compression? If they are bleeding PV, have you considered pregnancy? Or have you considered if their smear is up to date? With each consultation, consider what else would this be? What do I need to exclude? You always need to check, what are you supposed to exclude? Red flags. And this other one says, ineffective approach or prioritization in data gathering when presented with multiple or complex problems. So if a patient has multiple problems, you and I know that it will be difficult to do that in 12 minutes. Because you have 12 minutes for each case. So it's difficult to sort out multiple issues in 12 minutes. So what you have to do is you have to find out which one is most urgent, which ones can wait, and which one cannot wait. And you're giving a very nice example here. This may be about prioritization, recognizing the most pressing or important issues for this encounter and negotiating with the patient. For example, if a patient has hay fever, long-standing headaches, and bleeding on passing stool, we might agree to focus on the latter today. The latter is the bleeding, bleeding on passing stool, bleeding PR. So you need to focus on that. You see they've qualified this as long-standing headache. If it's an acute headache, obviously you want to pay attention to it. If the patient has a long-standing headache, it could be medication overuse headache, for instance, or it's unlikely to be something acute. So you focus on this. And if you have time, obviously, you can touch on the headaches very quickly, rule out red flags for the headache. Suppose you probably need to still rule out red flags for those headache, or if you're not able to do it, then obviously arrange, book the patient on the appointment to catch up with other symptoms, but pay attention to the most important, the most red flaggy sounding symptom prioritization. Next one is decision making or diagnosis was illogical, incorrect, or incomplete. And what they've said here is examiners felt that you failed to make the appropriate diagnosis and or the reasoning behind your conclusion did not make sense clinically. Remember the three domains in the SCA, data gathering and diagnosis is domain 1. Okay, management is domain 2. And then interpersonal skills or relating to others is domain 3. So domain 1 entails your data gathering and diagnosis, which means in every case, you must give a diagnosis. You must mention what your diagnosis is. From all you've told me, and looking at your investigation results, your blood test result, I suspect you might have what we call cholecystitis. Is this something you're familiar with? The patient will tell you yes or no. We say cholecystitis is when there's an inflammation of the gallbladder. Okay, and then you explain what the gallbladder is. Gallbladder is a pouch, of tissue that just lies just next to your liver. And what it does is normally stores bile. Explain all of those things and all of that. Try to keep your explanation short. Always check. Do you understand what I've said? Is that clear? Have you got any questions at this point? Chunking and checking with your patient. But you must give a diagnosis and give the diagnosis in the medical term and then explain what it is. Okay, so I suspect you have renal disease. I suspect you have multiple sclerosis. I suspect you have Dubin-Johnson syndrome. Explain what it is. Okay, and always check. Is this something you're familiar with? Check understanding, check knowledge, and then explain. So you must give a diagnosis in all your 12 cases in your SCA. Here it says, perhaps ECG provider showed atrial fibrillation, but you did not diagnose it. So you must give a diagnosis. Let's proceed. The next feedback statement says the management plan relating to referral was inappropriate or not reflective of current practice. You expected to show that your clinical management skills are in line with current UK best practice. And how best can you do this? To be honest, is to work with if you watched my previous video on the SCA preparation, I advise that you should familiarize with the health topics on 9CKS. So if you go to 9CKS topics, health topics A to Z, familiarize yourselves with the management, which entails investigations, treatments, referrals, on all the cases on that list A to Z. That you may not have developed a plan at all where a referral was needed, or you may have referred to an inappropriate place, or you may have referred when this was not necessary or appropriate. Very important. Okay, don't refer to pediatrics. Don't refer to the surgeons just because you're not sure what's going on. Therefore, let me refer to pediatrics to have a look. Would you rather consider keeping a symptom diary? That's something that could help. Maybe keep a symptom diary. Advise the parents keep a symptom diary of when the symptom happens and maybe things that happen, the food food that the child eats, around that period and things like that. Keep a symptom diary. Let's keep a symptom diary for the next 2 to 4 weeks and see how things evolve. As long as the child is safe to be at home, there's no, you could buy time by keeping symptom diaries. So consider that before you rush to refer. Okay, especially for mental health, things in children, maybe autism, ADHD, abnormal behaviors, and all those kind of things. You probably want to keep a symptom diary, or a child's suspected asthma in a child. You want to keep a symptom diary, query IBS, those kind of things. Or keep a food symptom diary for you to establish patterns. Okay, it says, okay, yeah, let's see. You should be familiar with current national guidelines, such as those published by the NICE and SIGN. Exactly what I've said. Let's move on. Next feedback statement says the plan relating to the medical management of risk was inappropriate or inadequate. I think this will be the last one. So about risk stratification, risk identification. Risk management prioritizes patient safety and ensures an appropriate response to preventing risk or managing error. Here it says, perhaps you did not seem aware of the responsibility for a systems response. For example, significant event analysis on the patient's process. For instance, a patient could be angry. A patient could be angry that maybe a wrong medication was prescribed, or something else, maybe it's prescribed for them or for their relative, or just angry that there was a late cancer diagnosis or referral for cancer assessment. A patient that eventually was diagnosed with cancer, for instance, the patient is just displeased with the care they've received, and the patient wants to complain. You need to be, of course, demonstrating empathy. I'm really sorry if this has happened. We need to look into it. Is there any particular way you want us to go about handling this issue? To find out how the patient might have, opinions on how they want this issue to be resolved or handled. So find out if they've got any particular, opinions or suggestions. And then you need to be telling them that, there's something called the significant event analysis meetings, SEA meetings, and you need to tell them about other complaints procedures. Coach level to make a formal complaint with practice manager, and then there'll be an SCA meeting, where these issues will be brought up, and then obviously a case and what's it called again? When meetings where you try to discuss the case, the causes, what led to that error or potential error happening. So it's all about risk assessment and risk certification, and then of course explaining to the patient the available resources, available MDTs, available meetings that will be in place to address those kind of complaints. Was the risk of overdose greater than the convenience of issuing 3 months of medication? So a patient who is depressed, you're seeing a depressed patient, you've agreed to commence the patient on an antidepressant, and patient might have some suicidal feelings, no active suicidal ideations, no active, no previous self-harm, but you're just worried that you might need to give a 2 weeks worth or a 1 month worth of medication and arrange a follow-up rather than giving 3 months, because if the patient overdoses on 3 months worth of medication, obviously the impact will be much worse than overdosing on 2 weeks or 4 weeks worth of medication. We need to be thinking about those kind of things. The temporary patient with no record received care without reference to the registered GP in a way that created risk. This is common in prescribing Z medications, Zopiclone, Zolpidem, or even certain high-risk medications, morphine for patients, for instance, who are temporarily registered in your practice, and you haven't got information from the previous practice. So in the exam, if a patient is coming to ask you for morphine, they say they're on holiday, they need morphine for their pain, prescribed by the GP, but they forgot it. You need to take that active step to explain that you need to contact their GP to clarify this, because you need to explain that it's nothing personal. They need to know it's not, you're not trying to victimize them, or this is a safety procedure that we need to go through to ensure that we're prescribing the right medication for you and for all our patients. So you need to explain that you have to contact the GP and asking the patients if they understand that. You're not trying to penalize them or victimize them, but these are safety procedures in place to ensure that all our patients are kept safe. And the patients usually would agree to that. Were documents shared without consideration of data protection, patient relative has come to you worried about something. They want to talk, have a discussion with you, the doctor, about your relative. Will you just loosely and carelessly share information without being sure that consent has been obtained from the patient before you divulge, certain information, or divulge certain information to the person who is asking? So we need to be careful about this kind of thing. So these are the feedback statements on RCGP SCA. So I'll just snip them and just say, let me have a chat about them, just so that if you're preparing for the exam, you know exactly what is expected of you. The holistic approach to your data, to your data gathering and your management. Very holistic approach is expected of you. I wish you all the best in your examination. Cheers, and thanks for your engagement.